Okay, this is finishing up the eating disorder for the 8 o'clock morning class, finishing of the eating disorders unit. We left off at starting on interventions. So interventions for clients with eating disorders. First of all, we need to establish the nutritional eating patterns or manage the person's nutrition. Usually when a person comes into the hospital for eating disorder, and again referring back to the table that I talked about that identified criteria for hospitalization for eating disorders, when they do come into the hospital, they usually are on a certain eating disorder program. And that eating disorder program is basically a program of privileges and restrictions that are based on compliance and weight gain. So it may be that there's a requirement for the client needs to gain 1 pound every week and to eat so many calories per day. And if they're able to do that and gain, a certain amount of pounds within, 3 or 4 weeks, then they can start to have certain privileges, which might be maybe starting to make out their own menus. It might be possibly going out on pass, but gradually starting to give them more responsibilities and more freedoms. But when they first come into the hospital, there are a lot of restrictions. They are told exactly what they need to eat. They are monitored constantly for how much they're eating and on a very strict calorie intake, I&O, that sort of thing. So it is very lots of constrictions and a lot of controls placed on them. So establishing the nutritional eating patterns. First of all, we need to get a dietitian consult. And that dietitian is going to come in and she is going to, through his or her assessment, determine the pounds per week that needs to be gained and then the calories per day that are needed in order to gain that pounds per week. The safest amount to gain per week is 1 to 2 pounds. We usually don't want to go over that, and to gradually start to have them gain weight back. We are also needing to sit with the clients during meals and snacks, and we usually limit their meal times to 30 minutes and to their snack times to 30 minutes. We don't really want to go over that 30 minutes. And if we have a time frame, then everybody knows what to expect. But if we let a person, they could possibly prolong a meal for 2 hours, 3 hours by refusing to eat or just playing with their food, that sort of thing. So we usually try to keep it at a time frame. We always sit with the client during meals and snacks so that they're supervised, so they aren't throwing their food on the floor, hiding their food, not doing something, cheeking their food, that sort of thing. So they have to be supervised, because if you think about these individuals and they have a severe fear of gaining weight, and to then be in a situation where we are requiring them to eat so many calories per day or so many calories per meal, that can be very, very difficult and can be very, very anxiety provoking. And so a lot of times what their first reaction is to, I don't want to eat this, what can I do not to eat it? So a lot of times we see manipulation. Usually then what happens if a person, within that 30 minutes, if a person does not consume all the calories or the meal or all the calories that they need to at that meal time, then we make up the calories with a liquid protein supplement like Ensure or Boost or something like that, whichever that particular hospital uses, and they have to drink whatever cc's in order to make up that calorie count. So they will be getting that certain calories every single meal or at snack. Okay, and so continuing on with that, we want to make sure that we're observing the client following meals as well, and snacks. So usually, again, so that they are not going into the bathroom and throwing up their food, so that they are not throwing away any food, that sort of thing. We observe them for 1 to 2 hours after they're eating. They may go and sit in the day room where we can observe them, or they may, if a group is going on for the next hour, they may go into that group and stay for an hour, but they have to be supervised following meals and snacks. If they are requesting to go use the restroom after a meal, staff have to go into the restroom with the person, and if it's a stall or if it's their own personal restroom, whatever, we have to actually be in the restroom with them and observing them the whole time. And as I've already talked about, but we need to be alert for them, hiding food, getting rid of food. We also need to be alert for attempts to hide food or to inflate weight. And that comes up especially when we're weighing a patient. We do, when a person is in for eating disorder, they usually do have a daily weight, and they are to be weighed in a uniform clothing at the same time every day. So most hospitals will have it be, 6 a.m. in the morning. The person goes into the person has to void and has to then put on a hospital gown with no bra, with no underwear, and then to get up on the scale and then to be weighed. Again, we want to void and make sure that they void so that they don't have a full bladder, so there's no chance of them, drinking tons of liquids in order to gain weight, for that short period of time. We also don't want them to be putting, something in their underwear or something in their bra which would increase their weight, okay? And they may be doing all that they can to try to manipulate that weight, to gain weight without actually gaining the weight so that they can get some of their privileges back, so they can have some more freedom. But we have to be very careful with that. Guidelines for refeeding is on page 468 in your book, and I want you to take a look at that. That should go nice. It needs to go very slowly. So I want you to read about that. There's always a possibility that if a patient is 100% refusing to take in any kind of food, calories, liquids, anything like that, there's always the chance that we may need to give them a tube feeding. And if sometimes patients are willing to take that tube feeding, have an NG tube placed, but many times patients do not want to do that, and so unfortunately sometimes we are doing that against their will. And if that's the case, then we would need to have that person be committed or to go to court to ask if we can take away those basic rights and force them to accept this treatment. All right. Next intervention, help the client identify emotions and develop non-food related coping strategies. So basically all the things that we've already talked about and all the other disorders about facilitating coping we would put in place here. Asking the client to really identify feelings that are going on, whether there might be depressed feelings, whether it might be anxious feelings, like we said, especially with individuals who are bulimic, talking about situations that evoke anxiety before they start that binging and purging, see if they can identify those. Explore, extreme fears that they might have about gaining weight. It might be also exploring feelings about their family or what their role is in the family. So again, very individual to that person, but exploring feelings, helping them talk about feelings and identify feelings. We may be asking them to do journaling and self-monitoring in journals. We're going to be doing a lot of relaxation techniques, things that we've talked about already about how to cope with anxiety or coping mechanisms. It might be guided imagery. It might be progressive muscle relaxation. Distraction can also be a coping mechanism. Distraction might be with hobbies, interests they have, such as reading or crafts or a wide variety of distractions or hobbies. We also want to assist the client to change any stereotypical beliefs that they might have related to the media, and to explore that and then start to examine, are those beliefs accurate and are they rational, and to start assisting them to change those. The next intervention on here, help client deal with body image issues and enhance their body image. Helping them to recognize benefits of a near normal weight, pros and cons. What are some of those benefits? If you are near normal weight, you are able to think better. You're able to, if they are in school, you're able to study better. You're able to cope with things better. you have the ability to take care of your family better, or whatever the case might be, but what are those benefits? And then help them to identify personal strengths, interests, and talents. If they are so focused on, that, their body image is what is making them successful or making them feel good or making them feel in control, that if we can start talking about, their personal strengths, what other things are in their life that they can get joy from or that they can feel good about themselves. We need to mobilize the family and help the family cope with the individual family member, but also to examine what is going on in the family. Do they need family therapy? Are there, some unresolved family conflicts? Is there unhealthy coping mechanisms within the family that need to be worked on as well? Another one, and that goes along with providing client and family education, page 469 in your book. I want you to take a look at that. A lot of education about what an eating disorder is, how to cope with the eating disorder, how family members may be enabling the person with the eating disorder, allowing them to continue unhealthy eating patterns and starvation, and how we can help educate that client and that family about that. Again, if family counseling is needed, which usually it is, to provide family counseling. Again, helping the family cope, but again, if there are issues such as enabling unhealthy, dynamics that are in that family, then family counseling is going to be very helpful. Helping the client to improve their self-esteem, and that would be with encouraging decision-making, helping them to become more independent, maybe become more autonomous from their family, develop some of that autonomy that they may be lacking, or just, only getting that autonomy through their eating disorder, but helping them develop autonomy outside of that eating disorder. And again, we can help that improve self-esteem by facilitating coping as well. Helping them to explore, why trying to achieve perfection is irrational, and is that possible to seek achieve perfection through your weight? Explore that kind of issue. And as nurses, we need to role model acceptance of imperfection and self-esteem, and we can model that by talking, possibly sharing some things about us, but that we are talking, making positive statements about ourselves, as well as people that we are encountering in the milieu. We also want to reduce anxiety, especially with bulimic patients, because that is a core issue many times with them, and why they binge and purge. And if we can try to, again, like I mentioned before, help them to talk about that anxiety, try to identify situations that evoke that anxiety, that's going to be a start there. And then relaxation techniques that go along with that. The other thing that I don't have on your, I just noticed that I do not have up on this PowerPoint, but that is in your outline, is managing fluid and electrolytes, especially in those people with bulimia. We need to make sure that we are doing a daily intake, I&O, and that they have adequate fluid intake. We need to be doing accurate daily weights. All those daily assessments, such as skin turgor, mucous membranes, vital signs, checking labs to make sure that they are hydrated. And then if we are noticing, imbalances in the fluids and electrolytes, notifying the doctor and getting orders to try to correct those. The patient may need an IV, so whatever that would require. Okay. Next slide. Okay, pharmacology in eating disorders. First of all, with anorexia, mainly we are going to be using antidepressants. As we mentioned before, with the concomitant disorders, many times people with anorexia also have depression. But besides just that concomitant disorder, there have been a lot of studies that are showing that there is some possibility that antidepressants like the SSRIs and SSNRIs can be helpful with decreasing anxiety and helping with anxiety. So this seems to help, as well as with some of the mood. Atypical antipsychotics such as olanzapine are also starting to be used with anorexia, and it seems that it is helps in a sense that it helps with some of the disturbed or irrational thought processes that the patient may have going on in their life or in their mind. Okay, like their body image and some of the irrational thoughts. Bulimia. Primarily, we are going to be using antidepressants such as SSRIs. Prozac is often used. This can help with, or it has shown to have some help with impulses of the binging and purging. Also, it can help with the mood, and if we increase the person's mood, that may decrease their preoccupation with weight and with their shape, and that may help along those lines. The last slide here is medical complications of eating disorders. And I don't have all these listed down. This is in your outline. First of all, you'll see where there's a section that's related to weight loss, and I want you to know all of those body systems and then the symptoms that can be complications of eating disorders, and I want you to know those. All of these are going to be important. Metabolic signs and symptoms are very important, as well as cardiac signs and symptoms, again, very important. With cardiac, you see that bradycardia, hypotension, and it also could be the orthostatic hypotension, especially related to dehydration. Of course, the reproductive, we see the amenorrhea there. Dermatology, complications, dry, cracking skin, again, related. A lot of this is related to the dehydration. Lanugo is a very fine baby-like hair that's all over the face, extremities, trunk, and many times we see this because the person's body fat has decreased so much that this lanugo is it starts to develop to actually to provide warmth or to have warmth. Often we see that in newborns have a fine hair over parts of their body in newborns. Okay, let's see. And then medical complications related to purging, and that's where the vomiting and laxative abuse comes in. Metabolically, again, that's very important to know all of that. The electrolyte abnormalities, especially like that hypokalemia, alkalosis, hypomagnesia, or magnesium, elevated BUN, concentrated urine. A lot of times what happens is that those electrolyte abnormalities start to then cause cardiac problems, and that can result in death. The GI, you can see there how some of the glands start to become inflamed. And just to know, and then Russell sign is on there as well, but just to know all those other body systems and the symptoms that would indicate there's a medical complication. And that's all that I have, and we are finished then with the eating disorder.